Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I have been a cardiologist at the Texas Medical Center for more than 30 years. Today, we are going to talk about syncope. Syncope is one of the most challenging problems which a cardiologist faces in his practice. And certainly, it has taken me the longest to prepare this presentation. Hopefully, we can shed some light as to what are the different types of conditions that can cause syncope and how we can precisely pinpoint the diagnosis and, more importantly, help these patients from having any further syncopal episodes, if at all possible. So, let us begin. The objectives of this presentation include the definition of syncope, etiology, epidemiology, pathology, classifications, etiology, history and physical examination, diagnostic and provocative tests, and most importantly, management and prevention of any further syncopal episodes. First of all, syncope is not a disease. Syncope is a symptom. Just like congestive heart failure is a syndrome, it is not a disease. Similarly, syncope is just a symptom, but is one of the most troubling symptoms for the patient, for the doctors, and the patient family. So let us get to the bottom of this problem. Syncope has 5 elements. It is characterized by loss of consciousness. There is loss of voluntary muscle tone, especially in the extremities. It is relatively rapid in onset. Recovery is spontaneous, complete, and usually prompt. Most often, it is related to a fall in systemic blood pressure. So, the bottom line is the underlying mechanism is transient global cerebral hypoperfusion. Let me repeat that again. Syncope is brought on by a transient global cerebral hypoperfusion. So, there are a number of conditions that can cause transient global cerebral hypoperfusion that can lead to syncope. Syncope is a multifactorial problem. It can involve the heart muscle, heart rhythm, can involve the nervous system, the autonomic nervous system, medications, age, vascular system, and many other entities. How prevalent is syncope? More than 1 million patients in the US present with syncope. More than 500,000 new patients are diagnosed to have syncope each year. Syncope accounts for 3% of the emergency room visits each year, and it accounts for 1 to 6% of hospital admissions. That's a pretty significant number, considering in majority of the cases that syncope is not a life-threatening issue. Of the 500,000 new syncope patients coming to the hospital each year, about 170,000 of them have recurrent syncope. And interestingly, 50 to 60% of the syncope can be explained by a process of elimination, but unfortunately, 35 to 45% of the time, the syncope may be infrequent and they may go unexplained. So, this is a very large troubling number. This is what we would like to reduce. So, we should be able to diagnose more and more patients with syncope because they all need help. Let's get down to some hemodynamic or physiology of what causes syncope. Earlier, I said in syncope, the underlying mechanism is transient global cerebral hypoperfusion. That means there is transient reduction in the blood supply to the brain tissue. This could be related to a reduced cardiac output, which goes back to the heart. Okay, let's look at what is cardiac output. Cardiac output is equal to stroke volume, that is the amount of blood the heart is pumping with each heartbeat, multiplied by the heart rate. Any one of the parameters that alter the stroke volume or the heart rate can result in syncope. If you further look into what are the things that contribute to the stroke volume, we have the contractility of the left ventricle. That is the pumping efficiency of the left ventricle. It can be altered with structural abnormalities of the myocardium, such as myocardial infarction, cardiomyopathies, or it could be also altered by significant obstruction to the flow of blood, such as aortic stenosis, mitral stenosis. But that's only one part of the story. The stroke volume is also dependent on the preload, that is the amount of blood coming into the heart, and the afterload, the resistance against which the heart has to pump. Any alterations in preload, such as volume, vasodilatation, venous pooling, or afterload, low blood pressure, vasodilatation, iatrogenic and postural and autonomic imbalances, they all can lead to reduced cardiac output. Heart rate, of course, this may be the easiest one to understand. Heart rates, both slow and fast, can lead to reduced cardiac output. That can lead to transient, global, cerebral hypoperfusion, resulting in transient loss of consciousness, which is known as syncope. Classification. There must be several hundred conditions that can cause syncope. But when you are examining a patient at bedside, or in the emergency room, or in the intensive care unit, how do you approach these patients? In order to simplify the approach, we can look at syncope into four broad categories. The first one is neurally mediated syncope, or NMS. The second one is orthostatic syncope, which is generally seen in middle-aged and older patients. Cardiac arrhythmias are another major component of syncope. And finally, structural heart diseases, including central nervous system disorders and pulmonary problems. If you look at here, the neurally, that is mediated by the sympathetic or the parasympathetic, more by the parasympathetic acetylcholine release. This accounts for close to 25 to 60% of the patients who present with syncope. And generally, these patients do recover fairly well. In this group, we have a common denominator, and that is the hyperactivity of the parasympathetic system with the discharge of acetylcholine, which causes all this havoc. So, the common conditions are, of course, vasovagal syncope, or the common faint carotid sinus syndrome, and a few other situational conditions such as cough, micturition, anxiety, fear, all of which lead to the activation of the parasympathetic system. Orthostatic hypotension, generally seen in older individuals, especially those who are on multiple drugs, and it can also be primary problem, like in patients with Parkinson's disease, or it could be secondary to various conditions such as diabetes, uremia, and spinal injury that can lead to autonomic imbalance. Cardiac arrhythmias, as I said, both brady and tachyarrhythmias can cause syncope. There's one more condition, long QT interval, which we are going to address in the future. Structural heart diseases, similarly, anything that reduces the flow of blood into the general circulation can result in syncope. Patients with aortic stenosis are well known to have syncope, and patients with mitral stenosis can also have syncope. Same thing with pulmonary hypertension, pulmonic stenosis, or hypertrophic cardiomyopathy, or acute medical conditions such as myocardial infarction, aortic dissection, or a stroke, or severe hemorrhage. If you look at the bottom here, majority of the syncope or in this group, which is generally benign. Then the orthostatic syncope accounts for 10 to 15%. Similarly, cardiac arrhythmias account for 10 to 15%, whereas the structural heart disease, central nervous system, and pulmonary causes account for only about 4 to 5%. But that leaves us with still 35% of the patients with syncope who are undiagnosed, for whom we cannot find an underlying cause. So this is the group we really need to focus on and see how this presentation can help you to figure out what is causing their syncope. Okay, let's look at this first group, which is neurally mediated syncope, or NMS. And in this category, we have the vasovagal syncope, which is the most common one, which is called the common faint. Then we have the carotid sinus syndrome, which is an extremely rare condition, but if it is diagnosed, we should be able to help these patients. Then we have this situational syncope, such as post-micturition, cough, swallowing, defecation, blood drawing, others. And this, everybody has seen this one. You know, you stick a needle in a person's arm, that person is going to pass out. That's the common fainting. Now let's try to understand what is this parasympathetic overflow that is causing all this havoc in these patients with vasovagal syncope. As we know, we have the sympathetic and the parasympathetic systems that control a lot of functions in the body, and particularly in the heart, in terms of the heart rate, the heart rhythm, and the vasomotor tone. When there is stimulation of the sympathetic system, for example, you get the fight response, where we have the increase in heart rate, increase in perfusion, increase in contractility, reduction in the PR interval. So all of these prepare you for the fight situation, that is through the adrenaline rush, as you commonly have heard it. On the other hand, when some people are presented with a frightful situation or anxiety, or if they are afraid of something, then there is the stimulation of the parasympathetic system through the vagus nerve, which causes release of acetylcholine in various parts of the body, including the heart, which leads to slowing of the heart rate, or almost coming to a pause for a couple of seconds. Then there is profound vasodilatation of both the arterial and the venous system, which leads a collapse in the intravascular volume. That leads to reduced cardiovascular output, and this can easily be reversed by just letting the person lie down, and by elevating the legs, we increase the venous return that will restore the intravascular volume, and thus these patients can regain consciousness by that particular maneuver. Having understood this pathophysiology of how autonomic nervous system can play a major role in the precipitation of these neurally mediated syncope, let us look at each one of these individually and see how we can understand the things that trigger these and how we can help these patients. The most common of which we know is the Vasodepressor syncope, or common faint. This is one of the most frequent causes of syncope. It accounts for 8 to 37% depending on what study you look at. This is generally seen in young patients without any structural heart disease. It is usually precipitated by a frightening, stressful situation. It can also be brought on by hunger, fatigue, dehydration, or hot, humid environment. And it is generally seen while the person is in a standing position, and occasionally while the person is sitting down. The premonitory signs would include nausea, blurred vision, the eyes get fuzzy, associated with warm feeling going all the way across the body, all the way down the body, sweating, pallor, and yawning. And when they actually faint, They appear pale and their pulses may be feeble or absent. Some of these episodes may be aborted or minimized by putting this patient in a supine position and elevating the legs all the way up. When they recover, they continue to have some degree of nausea and diaphoresis, and they feel extremely fatigued. They can't figure out what happened to them. Before we go into the carotid sinus syndrome, let's talk about there are baroreceptors located in the carotid sinus. Let me see if I can go back to the previous slide. Here are baroreceptors located in the carotid body, and these baroreceptors send the signal to the medullary cardiovascular center about the changes in the blood pressure. The stimulation of the baroreceptors leads to bradycardia. This is one of the things that we use, this important principle in slowing the heart rate in patients with atrial flutter or fibrillation to diagnose the underlying rhythm if we are not certain as to what type of rhythm we are dealing with. That is a carotid body massage which we do. In 1% of the syncopal patients, the carotid bodies may be super sensitive. With very slight changes, with just movement of the neck, their carotid bodies may get stimulated, which can lead to bradycardia and syncope. If we have done an extensive workup in a patient looking for syncope, if we can't find any other cause, we should look into carotid sinus syndrome by provoking the carotid sinus syncope, which I will explain in a couple of minutes. And as I said, it is generally seen in patients who are older than 50 years. Here's how we do the carotid sinus massage. Most of you are familiar with doing carotid sinus massage in patients with supraventricular tachycardia to determine the underlying rhythm. We use the same principle, but most importantly, we want to monitor these patients' pulse and blood pressure. You press their carotids for 10 to 15 seconds while monitoring their pulse and blood pressure. It should be avoided in patients who have a history of transient ischemic attacks or a stroke within the past 3 months, and also in patients who have a documented carotid bruise unless they had a Doppler study which excluded internal carotid artery stenosis. The carotid sinus massage is considered to be positive and diagnostic if it reproduces the asystole longer than 3 seconds, or if there is a systolic blood pressure drop of greater than 50 millimeters of mercury. We completed the first part. Now let's move on to orthostatic syncope. This is another very, very important topic, especially if you are dealing with elderly patients who are on multiple drugs, because every one of them could be the culprits, and it will be pretty challenging to figure out which one is affecting, and there could be a combination of the effect of drugs on top of an autonomic imbalance. It's not a very pretty sight. Okay. Orthostatic syncope. 30% of the people over age 65 fall each year. That is 1 out of every 3 people over the age of 65 fall. And 10% of those falls in the elderly persons are due to syncope. That is, they have a syncope first and then they fall. It's not that they fell and they passed out because they hit their head. That's a different story. Another important factor, 50% of the people who fall have a recurrence. How about that? The carotid sinus hypersensitivity is present in 23% of the people over age 50. That's a pretty high number, even though considering the number of patients, the percentage of people accounting for carotid artery syncope accounts for only 1% of the total syncope population. Now let's talk about orthostatic syncope. Orthostatic syncope can be related to an imbalance in the autonomic nervous system. Autonomic nervous system, we are talking about the sympathetic system that causes the heart rate to go up, the blood pressure to go up, and the increases the contractility, while the parasympathetic causes slowing of the heart rate, vasodilatation, drop in blood pressure, and somehow the imbalance in autonomic nervous system can be either transient or it could be permanent. That's where the real problem comes. Primary autonomic failure can be seen in patients with multiple system atrophy. That's with just aging. It gets it. You don't have much choice there if you have it. Parkinsonism is another condition which primarily affects the autonomic nervous system. Then secondary autonomic imbalance can be seen in patients with diabetes, people who are alcoholic, who have alcoholic neuropathy. Similarly, amyloid. Orthostatic intolerance as part of neuropathy can be seen in a variety of neurological conditions. And finally, we have the drug-induced orthostatic syncope. This is the biggest list I had to tell you. Here it covers all your antihypertensive drugs. It covers all your tranquilizers, which also drop the blood pressure. It also covers diuretics. So anything that decreases the intravascular volume, anything that decreases the peripheral resistance or the systemic vascular resistance, all these could be culprits in patients with syncope. It is especially so in the elderly patients who already have an underlying autonomic nervous system imbalance. If you add fuel to the fire, you're going to get into trouble. That's what happens with orthostatic syncope in the elderly patients who are on 8 to 10 drugs, who also have diabetes and peripheral neuropathy, or they have alcoholic neuropathy. Then we are going to run into problem in not only controlling their blood pressure, but also in preventing these drop attacks or syncope. Now let's move on to the third major category, which is the cardiac arrhythmias. It accounts for 10 to 14% of the syncope in the general medical practice. Cardiac arrhythmias can cause syncope, and bradycardia accounts for 36% of the patients with recurrent syncope, whereas tachyarrhythmias are much less compared to bradycardia. However, a majority of them may have normal sinus rhythm, and there may be a different cause altogether, such as volume changes. Now let's look at rhythm problems. As I said, they account for 10 to 15% of the syncope. Both the slow rate and the fast rate are a big headache, because they can cause syncope by reducing the stroke volume or by reducing the rate. All these things like sinus pauses, AV block, or supraventricular tachycardia or ventricular tachycardia. And one more condition that we need to look into is the prolonged QT interval or prolonged QT syndrome. Prolonged QT syndrome can lead to torsade, that is a virulent form of ventricular tachycardia, or that can lead to transient reduced global perfusion that causes syncope. Here's a long laundry list of drugs that can produce prolonged QT interval, starting with antiarrhythmics. The very drugs that we give to prevent arrhythmias can become pro-arrhythmogenic, and that's an important thing that we need to keep in mind, because some of these drugs can produce torsade. Anti-anginal medicines such as Bepredil, psychotropic drugs such as amitriptyline and all these other drugs, antibiotics, in fact, erythromycin and fluconazole, and sedatives such as terfenadine and estomazole, and a few others. So when you are looking at a prolonged QT interval on a resting electrocardiogram, we are looking at prolonged QTC, which is a corrected QT interval, we should always look at the drug list and see, is there a drug that is prolonging the QT interval? If it is, you may be able to stop the drug and hopefully minimize the recurrence of a syncope in that particular patient. Now let's move on to the final category, but this may not be the final category. There may be another category which has a list of miscellaneous conditions that can account for syncope. Structural heart diseases are another important contributor to syncope in patients. Of course, patients with ischemic heart disease who have myocardial infarction, or patients who have coronary artery disease or congenital coronary anomalies, people with hypertrophic cardiomyopathy, or people who have acute aortic dissection, pulmonary embolus, pericardial tamponade, pulmonary hypertension, pulmonic stenosis, and valvular problems such as aortic stenosis, mitral stenosis, and tumors such as atrial myxoma. All these things can interfere with the stroke volume. As I said in the beginning, cardiac output is related to stroke volume multiplied by heart rate. The structural heart disease predominantly hit the stroke volume because they cannot pump efficiently, or they can pump efficiently but there is some obstruction to the forward flow, like in patients with hypertrophic cardiomyopathy, aortic stenosis, or pulmonic stenosis. So whenever there is reduced cardiac output coming from the structural problems of the heart, they usually carry a much poorer prognosis, but we should be able to diagnose them fairly easily because of the clinical presentation and also because of the number of tests we have to diagnose these underlying conditions. The next section is, how do you approach an individual patient who has passed out? I mean, that's the bottom line, is it not? Okay, let's look at it. We need to take a detailed history. History is one of the most important points in diagnosing a patient with syncope. History can give us a lot of information about what kind of the presentation the patient had, what is his underlying medical problem, what are the diseases this patient has that can predispose to syncope, and most importantly, the medications this patient is taking. When you take a detailed history, if you are dealing with a patient with syncope, I would say spend most time in taking a very detailed history. History itself can give us information in almost 30% of the patients with syncope. Of course, we're going to do diagnostic tests to confirm it, but the history will send you in the direction of where to look for additional diagnostic information. We're going to expand on the history in a minute. And examination. When we are examining a patient for syncope, we need to look for general appearance, pulse, respirations, differential blood pressures in the arms, and especially orthostatic blood pressure. We should record their blood pressure while lying, while sitting up, and while standing. And this should be done 3 to 4 times, and the patient should be encouraged to record their blood pressures at home. And this is very useful in patients with orthostatic syncope. Similarly, we need to look for jugular venous distension, which can suggest heart failure or tamponade, and look for carotid bruise. Always listen to the neck for carotid bruise. If you hear a loud bruise, a carotid duplex scan may show evidence of critical internal carotid artery stenosis. And similarly, we look for heart murmurs. Heart murmurs can point towards aortic stenosis, mitral stenosis, hypertrophic cardiomyopathy, and a whole bunch of other conditions. The diagnostic tests are fairly simple, contrary to what you would think for a disease that is so complex, because simple things like electrocardiogram, echocardiogram, a chest x-ray basically will help us to sort of come to a conclusion as to the direction in which we are going. We may not be able to make a final diagnosis, but at least a direction in which we need to proceed in terms of identifying the cause for syncope. Then we have the provocative tests such as the tilt table test, the head tilt test, electrophysiologic studies by using stimulation or carotid sinus stimulation. Let's look at the history a little more detail. When we are taking a history, we should first of all try to understand, did the patient really have a true syncope, or was this a seizure? We'll talk about differential diagnosis later on. What was the person doing? Was the person standing? Did the person have palpitations? Did the person have seizure activity, or did they have a history of seizure activity? Was the patient taking medications of any sort? Were there prodrome syndromes? Did the patient have residual symptoms after that? Then the whole systemic approach should include diseases involving the central nervous system, the pulmonary system, the cardiovascular system, the GI system, and the peripheral arterial system also. When we take a detailed history, it tells us a lot about the patient's overall makeup and what could be precipitating this patient's syncope. Does the patient have stress? Is the patient anxious? Is there anything in his life that triggers these type of episodes? I had a patient today, and he said every time he walks into a big grocery store like Walmart, he has the symptoms. When he walks into Sam's, he has these prodromal symptoms. In fact, I put a heart rate monitor on him, and I said, okay, why don't you go to Walmart and Sam's and see if you can precipitate this, so that we can pinpoint the cause of your syncope. Okay, electrocardiogram is very important. It's a very simple test, but it can tell us a lot about what's happening. Electrocardiogram may be abnormal in 50% of the patients with syncope. It identifies potential causes in 2 to 11% of the patients. We are talking basic resting electrocardiogram. The beauty is resting electrocardiogram can detect a lot of things like bradyarrhythmias, pre-excitation, ventricular hypertrophy, and of course you need electrocardiogram to look for a prolonged QT interval, Brugada syndrome, and other types of conditions that can cause syncope. So we start off with a basic electrocardiogram, and then we go on to the next one. Of course, the echocardiogram is excellent for looking for structural heart disease. This is one of the best tests to look for structural heart disease, because even nuclear stress test won't tell you about the structural heart disease as much as an echocardiogram can. Here we can identify myxomas, hypertrophic cardiomyopathy, or congestive cardiomyopathy, valvular stenosis and leaks, ischemic heart disease, and of course right ventricular abnormalities. Echocardiogram also provides a prognostic indication, tilt table testing. In those patients where we have done all these basic tests and where we have not been able to come to a conclusion as to what exactly is causing their syncope, especially in the first neurally mediated syncope group, we can look at doing a tilt test to see if we can trigger the vasovagal syncope in these patients. By using the tilt table test, the results are characterized by initial normal reflex to standing, followed by a rapid fall in venous return and vasovagal reaction, that is reflex bradycardia and vasodilatation. However, the test is of very limited value because of low specificity, sensitivity, and reproducibility. Is tilt table test. I don't know how you would like to be strapped to this table and standing there steady like a soldier for 40-45 minutes. Why, if that's what you need to get your heart checked out, I guess you have to take it. Here's another one, head up tilt test, which is HUT, and this unmasked vasovagal susceptibility. It can reproduce symptoms, and it helps the patients and the physicians to come up with a game plan. Electrophysiologic studies. Electrophysiologic studies are needed in a very, very small percentage of patients. We are talking like 3 to 5% of the patients with syncope who will end up needing electrophysiologic studies, because most of them can be diagnosed based on the simple diagnostic tests, and most importantly the history and physical examinations. Class 1 indications is for patients with a structural heart disease who have unexplained syncope, that is structural heart disease whose syncope is unexplained. If the patients experience palpitations before or after the syncope, that may be an indication to look for any type of arrhythmias that may be precipitating syncope and help us in a game plan as to how to treat these patients. EEG. Because the neurological causes are so rare in terms of causing syncope, EEG may be able to help us in differentiating between true syncope and seizure disorder. That's the only time an EEG will be helpful. Okay, now central nervous system disorders. A number of central nervous system disorders can cause syncope. A cerebrovascular accident can result in syncope. What are the tests that we can do as far as finding pathology in the central nervous system? Of course, we have the carotid arteries, on which we can perform the duplex scan to look for critical stenosis. Then we can do a head CT. Only if the patient has experienced focal neurological deficit or they have experienced head trauma from the event. Similarly, if we are suspecting posterior circulation, MR angiography or CT angiography may be necessary to do. Again, as I said, these instances are so rare, they do not produce significant results. Now, let's put all our patient evaluation, including history, physical examination, and the diagnostic tests, and see which one of these really stick out in terms of identifying patients with a particular type of syncope. History, physical examination, ECG, and carotid cardiac massage. It should be carotid massage. Can identify 38 to 40% of the patients with syncope. So that's where you need to put your money or put your hands, because you need to focus on history, physical examination, ECG, and perhaps maybe a carotid massage. Now look at some of these more expensive tests. Head tilt can only help in 26% yield. External cardiac monitoring, 5 to 13%. The only time if you are dealing with an arrhythmia and you cannot really pinpoint or pick up what kind of arrhythmia the person is having, then an insertable loop recorder, which can stay in the body for 6 months to a 12-month period, is quite effective in picking up these arrhythmias with a success rate ranging from 40 to 80%. So that's the only time when a monitoring device can purely come into play in terms of identifying an underlying cause for syncope. As I told you earlier, the EP studies have a very, very poor yield ranging from 2 to 5%. And similarly, exercise test is not the best test to look for syncope. Again, EEG has a similarly poor yield when it comes to diagnosing a patient with syncope. Now let's talk about differential diagnosis. Not everything that glitters is gold. Not everything that falls on the floor is related to syncope. People can trip over and fall. If it's a banana peel, you can just slide over and fall. If you're having a seizure, you can slide over and fall. So syncope, we need to look at differential diagnosis. There's a pre-syncope, which is characterized by lightheadedness without loss of consciousness. Then we have the drop attack, loss of posture without loss of consciousness. This can happen in patients with muscular problems, muscular dystrophies, loss of consciousness without spontaneous recovery. Then, of course, the seizures, which can be an important differential diagnosis when we are dealing, because they sort of present in a similar manner, but they do differ in certain respects. Similarly, these metabolic conditions such as hypoglycemia, hypoxia, including transient ischemic attack or cardiac arrest, All these can come into the differential diagnosis of patients with syncope. How do we differentiate true syncope from other causes of loss of consciousness, such as seizures, psychiatric disturbances? Let's look at here. Syncope versus seizure. Syncope usually begins in a standing position, whereas seizures can occur in any position. Even syncope, if it's related to cardiac arrhythmia, can occur even if the patient is lying down. Often, syncope is associated with prodromal symptoms of nausea, warmth, pallor, lightheadedness, diaphoresis, and seizures usually have jerky motions during periods of unconsciousness. Consciousness is regained spontaneously and fully aware of the surroundings. Post-ictal period, patients with seizure have confusion and drowsiness. So these are some of the subtle differences that will help us to differentiate between a true syncope and a patient with a seizure. When to admit a patient to the hospital? After you've taken the history, you've examined the patient, you've done the basic laboratory studies, now when do you admit these patients? Who do you admit and who do you send home? These patients have structural heart disease. With a syncope, they need to be admitted. If there are EKG abnormalities suggesting arrhythmias, again they need to be admitted. If the syncope occurs during exercise, that's a poor prognosis. These patients need to be admitted and evaluated. Especially syncope happening during sporting event, they need to be admitted and evaluated. Syncope occurring in a supine position, that's unusual, so that needs further investigation. Syncope causing severe injury, family history of sudden death, or if the patient complains of palpitations or recurrent episodes of syncope. All these are indications that these patients need to be admitted to the hospital, observed, and further testing done. Okay, it's about time we talk about treatment. Let's move on to the treatment part. Vasovagal syncope. Vasovagal syncope, as I told you, is an autonomic nervous system imbalance. There is hyperactivity of the parasympathetic system through the acetylcholine, which is transmitted through the vagus nerve, causing bradycardia, slowing of the heart rate, profound vasodilatation of the arterial and the venous circulation. So we need to see how we can focus on that one. In these patients, giving salt tablets and giving some fludrocortisone to improve their vascular tone might help. Beta blockers also help. Disopyramide, which is also an agent, helpful. And similarly, these SSRIs, which interfere with the serotonin in the brain, may also help. And finally, vasoconstrictors like midodrine may be helpful in certain patients. Let's look at some of the things that the patients can do when they are having a suspected vasovagal syncope. This can include crossing the legs or tugging the arms, lowering the head, or best lying down. And if we can elevate their legs all the way up, that will improve the venous return to the heart and minimize the symptoms of syncope. Pacing is only indicated in extreme cases of patients with vasovagal syncope who have a positive HUT test and cardio-inhibitory or mixed reflex on this test. Educating the patient about how to anticipate some of these events and how to minimize by being prepared. Being prepared is far more important than taking any drugs. Here, this chart sort of summarizes all the things that can be done. One, to improve the preload, we can give these patients fluid, salt or salt drinks, compression hose, steroids, alpha-adrenergic agonists such as midodrine, which causes vasoconstriction in the arms and legs and thus maintains the vasomotor tone, anticholinergic agents which block the acetylcholine effect on the receptors can help in reducing the effect of the autonomic nervous system discharge. The drugs such as propanthelin, disopyramide, hyoscyamine, they are all useful in reducing the vagal effect on the heart and vascular system. If we have an AV re-entry tachycardia, they can be treated with ablation. If we have a AV nodal re-entry tachycardia, they also can be subjected to ablation of the slow pathway. Atrial fibrillation. These patients can be treated with focal ablation or by ICD placement along with a pacing device. Atrial flutter is one of the easiest one to ablate and thus eliminate the flutter and prevent any syncope. Ventricular tachycardias are much more challenging. If the patients have ventricular tachycardia in the presence of a low left ventricular ejection fraction, they are best served by intracardiac defibrillators. If the patients are having torsade, withdrawal of the offending drug may help to stabilize the rhythm. Treatment of long QT syndrome. There are two types of long QT syndromes. One is a congenital long QT syndrome, which is generally seen in young adults, and the type of long QT syndrome we see in the adult population is usually related to drugs. We give you a long list of drugs. By removing these drugs, we may be able to minimize the development of torsade. In an emergency situation, we give these patients intravenous magnesium. Sometimes we can use pacing to overcome bradycardia or pauses. Isoprel can also be used to increase the heart rate and shorten the repolarization. ICD may be recommended in patients with significant arrhythmias or a strong family history of sudden death. If this is drug-induced, we withdraw the drug. If it's genetic, avoid all QT prolonging agents. Here's an example of pacing in patients with carotid sinus syndrome. And you can see those patients who were paced had 9% incidence of adverse events such as syncope compared to those who were not paced. So there is a role for a pacemaker such as DDD or DDI pacemaker in a patient with hypersensitive carotid body. Okay, here's an example of midodrine, an alpha stimulant which causes vasoconstriction in the leg, and you can see the difference here in terms of outcomes. People who took midodrine were able to maintain their blood pressures, and this is especially used in patients with orthostatic hypotension for whom it is a chronic problem because they have fixed changes in their autonomic nervous system, which is of course altered. And by providing them with this midodrine, we are able to maintain their vascular tone and thus prevent any vasodilatation that leads to profound drop in the venous return that leads to reduced cardiac output. So this is a long overview of a long due topic, syncope, because syncope is so complex because it involves so many multiple systems. It takes a lot of effort to put all the pieces together. Hopefully this has shed some light on what causes syncope, what are the different classifications of syncope, how do these patients present, and how do we diagnose them, how do we treat them, and how do we most importantly prevent from getting these episodes. Patient education is a very important aspect of dealing with syncope. Thank you, ladies and gentlemen. Please do subscribe to our YouTube channel, and we will see you next time. I am Dr. Nik Nikam.